Morning, everyone. We are glad you're here with us today, and we'll give a couple more minutes just until we have everybody in the room. Okay, we're going to go ahead and get started. My name is Lindsay Wyckoff, and I'm the Director of Volunteer and Community Strategy for the American Cancer Society, and it is my absolute pleasure to welcome you to our event today. We ask that if you have multiple people listening from one line, that you please enter your names and organizations in the chat so we have a record of your attendance. Attendance for everyone else will be recorded automatically. During the program, all lines will be muted, and we ask that questions be answered through the Q&A tab on your screen. We will be taking audience questions during our panel discussion as time permits. If we do not have time to answer your question during the panel, we'll work with the presenters to make sure that we have an answer to your question post-event. As we get started, we would love to learn a little bit more about who's joining us today. Please answer the poll question on the screen and let us know what sector you represent. Okay. Thank you for putting those names in the chat. We appreciate it. Hopefully, just waiting on those poll results. Okay, awesome. So I have a wide range joining us today, so we really appreciate you all being here. Before we begin our program, we want to recognize and thank our sponsors. Without the generous support of The Ohio State University Comprehensive Cancer Center, the James Cancer Hospital, this program would not be possible. Also, thank you to the Ohio Partners for Cancer Control and Mountains of Hope Comprehensive Cancer Coalitions for their continued support. Here's our agenda for today. We'll start with a mission story, followed by our four presenters. Following the presentations, the speakers will join us for a panel discussion, and then we'll conclude with some resources and housekeeping items. The AAFP has reviewed navigating current issues in cancer caregiver support during cancer care and deemed it acceptable for up to 2 enduring materials self-study AAFP prescribed credits. You will receive a certificate to claim your CEs within 2 weeks following completion of the post-event survey. Our objectives for today's event can be seen on the current slide. The planning committee members and speakers have declared that there are no relative financial arrangements or affiliations with the organization that may affect balance, independency, objectivity, or scientific rigor for the CE event other than those disclosed on this slide. Also, please note that the slides will be available after the presentation, and we're recording this event and it will be posted on YouTube after the fact. If you've come to one of these before, you know that we begin each session with acknowledging some of the individuals who are affected by the topic at hand. It is my absolute pleasure to introduce Deborah Cahill to you. Over the course of her life, Deborah has held many roles: daughter, student, high school teacher, reference librarian, tutor for pregnant teens, mother, and wife. But none have challenged her more than serving as a caregiver for loved ones facing cancer. As a caregiver to her father, daughter, and husband, Jim, she has experienced firsthand the challenges, resilience, and deep commitment that caregiving requires. Deborah and Jim also spent time at the American Cancer Society Hope Lodge in Cleveland during his treatment and recovery. She has shared how the warmth of the facility, the support of staff and fellow residents, and the sense of community they found there played an important role in their journey. Today, Deborah has graciously offered to join us and share her lived experience as a caregiver and the lessons she learned while supporting the people she loves through cancer. So, someone I met at our Hope Lodge in Cleveland. So, Deborah, thank you so much for being here today, and we're happy that you're here.
Thank you so much. Thank you for the invitation to speak today. And Lindsay and her mother provided Christmas dinner when Jim and I were at Hope Lodge, Christmas before this one. And I'll always remember her and her mother's kindness. So I've been thinking a lot since I was asked to speak at this presentation about being a caregiver. I think for everyone, but maybe especially for women, uh, we're we're just caregivers of our parents, of our children, and it comes naturally. And I think sometimes we just accept that role with joy and gratitude. But we also don't look at the toll that sometimes caregiving can take on us. And I'd like to start with a quote from Rosalind Carter, a lady that I admire greatly. She said, "There are only four kinds of people in this world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need a caregiver." And as I read over the notes that were shared with me about the navigating the current issues, the one that really resonated with me and the one that I would like to hone in on is the one on effective communication strategies. I think in my role as a caregiver, a cancer caregiver, that is, to my father, unfortunately, our beautiful daughter, and my husband, um, communication sometimes is where support for me broke down. And I'd like to give you a couple examples from each of my experiences with my family members. We live in a small town, Dover, Ohio, about 85 miles south of Cleveland. And when my father was diagnosed with cancer, he and my mother lived in Florida. My mother had some issues of her own and could not be a caregiver. So I became my father's primary caregiver and tried to fly to Florida every other weekend while working and having my family here. And what I really needed was strong communication from my father's medical team in Florida. And it was really lacking. And one example would be when I called his social worker one time when I was noticing concerns that the end of life might be drawing near, she said, "Excuse me, I'm in the middle of doing dishes and it's almost story time for my children, and I don't have much time to talk with you, but I will try to talk with you and answer some of your concerns while I'm doing dishes." And I could hear the water in the background and all. And that came at a time when I really needed her attention. Our daughter, when she was diagnosed with cancer, was living in California. And although we were lucky enough to have the ability to fly to California often and be with her, we still had to come back home to Ohio from time to time. And our communication again was through mostly her social worker. And when it became an end of lifetime, unfortunately, it was COVID time. So our family, she was only allowed one person in her room at a time. And the social worker was going to be the liaison. And we got very little communication with her, very little help at a time when we absolutely needed it. And I understand that was a special time and they were probably short staffed with COVID. But again, I didn't feel like we had effective communication strategies. Um, One other thing is after our daughter passed, because she was in hospice care at the end of her life, I was offered counseling through hospice. And I just want to talk a little bit about the challenges of living in a small town, not near a major medical center. So we do have a small hospice facility here, and I was told that I could talk to a counselor, um, a grief counselor, or join a support group of other parents that had lost children. But there wasn't enough interest in our little town. And when I tried to connect with a larger hospice group in Canton, they didn't have a group for me, nor did they have a free counselor. So that kind of fell by the wayside too. Recently, this was my husband's second stem cell transplant. He relapsed after the first one, and his amazing medical team came together and decided that despite the odds being way against him, they would try for a second bone marrow transplant at age 73. The pre chemo and radiation was grueling. He was already in a weakened state from AML. And after the transplant, he was obviously very ill. And since this was my second time, I knew that pretty much what to expect. One day, a social worker came into our hospital room in Cleveland, identified herself as a social worker, but I had never met her before. And she said, "Are you Mrs. Cahill? Here is a list of nursing homes. Pick one. I'll be back in 2 hours. And we're going to transfer your husband to a nursing home because there's nothing more we can do for him here." I was taken aback. I had never met this person before. No member of his medical team had told me that this was going to be the next step. She told me to circle the first two that I wanted, and they would try to secure him a place in one of our choices, but they couldn't guarantee it. I, like I said, I was dumbfounded. This had never come up. And I knew from his previous stem cell transplant that it was too early to find out that whether or not engraftment had happened. So, needless to say, the next day, engraftment happened and the subject never came up again. So I guess I know my time is running low, but I just want to challenge all of the social workers, the nurses, the caregivers, that communication with the family, not having them be blindsided, is so important to the mental health of the caregiver. Thank you so much for listening to me. I appreciate all of you.
Thank you so much, Deborah. And as you mentioned, we met on Christmas Day, and it just was so special to be with your family. And Remembering Jim's salad. It's a summer salad. It's got all that fresh fruit in it, so I might be making that this weekend. So wishing you guys all the best. Just
Thank
you guys are
you.
so wonderful. So thank you for being here.
And real quickly, I did not mean for this to be a complaint. I want you all to know that his medical team his was fabulous, but I just viewed this as an opportunity to challenge you to communicate better with the caregivers. Thank you so much.
Absolutely. Thank you. We're going to move into our first presenter, Dr. Susan Mazanick, I'm sorry. Dr. Mazanick is an associate professor at Francis Payne Bolton School of Nursing at Case Western Reserve University, a member of the Case Comprehensive Cancer Center, and a nurse scientist at University Hospital Seidman Cancer Center. Her research focuses on cancer survivorship, symptom management, and the experiences of family caregivers of patients with cancer. She has led multiple federally funded studies, including National Cancer Institute supported work to improve to improve caregiver training, patient outcomes, and supportive cancer through innovative interventions such as simulation-based education. And I'm so sorry if my dog was barking in the background during that intro, but Dr. Maznick, thank you for being here, and I'll turn it over to you.
Sure, thank you. And good morning to everyone. And thank you for this opportunity to participate in this very important discussion. Next slide. I'd like to begin my presentation by gratefully acknowledging the National Cancer Institute and the American Cancer Society for supporting my research throughout my career. Thank you. Next slide, please. In 2026, it is estimated that there will be 2.1 million new cancer cases in the United States, and 19 million individuals are living with a history of cancer. Now, the prevalence of cancer family caregivers is estimated to be as high as 6 million in the United States. However, I believe that it's likely much higher. Next slide. The experience of cancer and cancer treatment extends beyond the patient to the social network of the patient. Person-centered care must include family caregivers, which is defined broadly as an adult providing support and care to a person with cancer. Family caregivers are essential for maintaining the patient's physical and mental well-being throughout cancer treatment. And although they are an integral part of the care team, they are rarely recognized and acknowledged. Next slide, please. The multidimensional impact of cancer on family caregivers is very well documented. There have been numerous descriptive studies for many years, but there is little application of our knowledge in the real world in clinical practice, specifically related to how research interventions are designed and implemented and translated to practice. Next slide, please. Considering the new therapeutics and the resulting dramatic shift in oncology care to the home, the impact of cancer on family caregivers is substantial. Cancer caregiving can be very complex and intense, particularly within the context of combined modality treatment that is associated with a very high symptom burden and the need for family involvement. I believe we are pushing the boundaries, back please, we are pushing the boundaries of family caregiving. We're adding new advanced responsibilities in addition to the routine responsibilities for the caregiver. And also another trend is that the duration of caregiving has become more prolonged as treatments have extended well beyond the initial treatment into survivorship. Next slide, please. Family caregivers provide a wide range of supportive activities, And it's estimated to be as high as 75% of caregivers are performing medical nursing tasks such as wound care, tracheostomy care, tube feedings, ostomy care, and symptom management. However, 50 to 58% of cancer caregivers report unmet training needs. And this is a national problem that really extends to other caregiving populations as well. And the study that I will present in just a minute is addressing this gap. Next slide, please. We know from studies of caregivers of individuals with dementia that caregiving is potentially a chronic stress condition with potential for negative health issues in the caregiver, both physical and mental. The caregiver role can lead to caregiver burden, which is the caregiver's perception of the impact of their role on the many aspects of their life. Burden often goes unrecognized by the healthcare team. In addition to the potential for influencing patient health, burden can potentially influence both the patient and caregiver engagement in clinical research. And this has very serious implications for the advancement of clinical trials. The sense of burden can affect enrollment in trials, meeting trial requirements, and dropout rates as well. Next slide. There are many transitions along the continuum of cancer care, and in my preliminary studies, I focused specifically at the end of the transition at the end of curative treatment. This is a critical period when self-management skills shift and caregiving skills are needed. It is also a time when there's quite a bit of emotion in both the patient and the caregiver. In my early studies, I found that the family members were thinking about their own health and health behaviors as a result of the cancer experience. I also found that family members had a higher distress score than the patient at the end of treatment. And we know that caregiver distress is a problem. This has been well documented. And we also know that caregiver distress is a risk factor for vulnerability long-term, meaning we need to address this early in the trajectory of the experience of cancer. And so I found that the end of treatment is possibly a teachable moment for health promotion for both the patient and the family member. Next slide, please. I just want to briefly share with you a clinical trial that I recently completed and give you some preliminary results to it. Next slide. This is a psychoeducational intervention that included simulation, and that's what made this intervention unique. Simulation, which is commonly used in training of healthcare professionals, physicians, nurses, it's a form of experiential learning that creates events to mimic clinical situations. The learner is able to solve problems, make decisions, and practice skills in a very safe, supportive environment. Despite this, I found that it was rarely used in the training of family caregivers. The intervention is delivered in person, in the clinic, in real time, existing along the trajectory of treatment that the patient is going through. There were 3 sessions, each with a theme, and the sessions were designed to align with what we anticipate and know that the patient's needs are going to be as well as caregiver needs. Each session had a standard format with a great deal of flexibility to meet the caregiver needs. First, the nurse attended to the caregiver's immediate concerns, just like you would in clinical practice. And also, we assessed the caregiver's distress. Then the nurse interventionist moved to providing information and educating the caregiver relevant to the theme of the session. And then that was followed by structured simulation experiences to practice both technical and communication and health promotion skills. Next slide. This is a two-group randomized controlled trial. The primary aim of this study was to test the intervention on caregiver self-efficacy for caregiving, anxiety, depression, fatigue, and health-related quality of life. And we also measured patient outcomes and healthcare utilization outcomes. We enrolled patients with a diagnosis of head and neck, anal, and rectal cancers, as well as advanced stage esophageal and lung cancers. These patients are typically receiving concurrent chemotherapy and have a very high symptom burden during treatment. Caregivers were identified by the patients as their primary caregiver. Caregivers randomized to the control group received usual care and a caregiving booklet. The intervention group received the booklets, usual care, and then the sessions with the nurse interventionist. And we took measurements at 4 time points. Next slide, please. And I just want to share some of the preliminary results and some key findings with you. We enrolled 244 patient caregiver dyads. And the first finding that we found is that the intervention increased self-efficacy for caregiving. And this was statistically significant. Caregivers in the intervention group had greater self-efficacy for caregiving. And this was a persistent effect over time throughout the study. We also found that caregivers in the intervention group had less fatigue than the caregivers in the control group. And this was not too surprising in that the intervention components had a very significant focus on caregiver health strategies, stress reduction. And, it really indicates that intervening with a caregiver during treatment can promote their well-being. Other than that, there were no statistically significant intervention effects or differences between the groups on the other outcomes that we were measuring in both the caregiver and the patient and healthcare utilization outcomes. We're still analyzing the data, of course, but we're looking specifically at the situation that we had in that patients with head and neck cancer comprised 50% of the sample. And we did find that caregivers of patients with head and neck cancer had greater anxiety, fatigue, and depression than other caregivers. And we realize and recognize that caregiving in the context of head and neck cancer is extremely challenging, and perhaps more intensive intervention is needed for that group. So, and the analysis continues, and there's much to learn. But I am going to stop at that point so that we can have a good discussion in just a few minutes. Thank you.
Thank you so much, Dr. Masnick. That was so important. And thank you for the work that you're doing, as our caregivers need the support too. And so that research is so critical. Presenting next is Alexandria Kizlyakov. Alexandria is a therapist with psychosocial oncology at the James Cancer Center, where she specializes in harm reduction counseling for individuals with a cancer diagnosis and current or past substance use concerns. She has several years of oncology experience, including work in cancer survivorship and active oncology social work care, as well as experience in home health and inpatient hospice care. Her practice is grounded in a grief and bereavement framework, which she uses in individual care and to support grief education for clinical staff at Ohio State University. Welcome, Alexandria.
Hello, everyone. Good morning. I'm going to talk about a few different elements of grief and caregiving today. If you could go to the next slide, please. So a couple of different types of grief. There are various types of grief out there in life and in the medical field, but I'm just going to highlight a few of the specific types of grief that I believe really relate to caregiving today. So general grief, the Merriam-Webster dictionary defines grief as a deep and poignant distress caused by or as if by bereavement. So I think one of the main things to remember with general grief is that there is an identifiable loss. So an example of this is a spouse passes away. Another type of grief is cumulative grief. So can be described as multiple losses over time, with each new loss bringing up feelings surrounding past loss. So an example of cumulative loss would be, or cumulative grief would be losing a close friend in 2020, a sibling in 2022, and a parent in 2024. So each new loss can bring emotions from previous losses, and the grief begins to accumulate. Another type of grief that is relevant in caregiving situations is disenfranchised grief. So this is grief that is not often recognized by society. A good example of this is pet loss. So if someone loses a pet, typically the bereavement days allotted for work do not include pet loss. They emphasize, immediate family members, things like that. There's very specific rules. Another type of grief is anticipatory grief. So this, I believe, is the type of grief that most commonly relates to caregiving, as it is grief that is experienced prior to the loss of a loved one. So I'm going to expand more upon anticipatory grief. We can go to the next slide. So what does anticipatory grief entail? It is often associated with caregiving. It includes grief surrounding normalcy in life. So, for example, schedules can shift to focus on doctor's appointments, medication schedules, routines and schedules as individuals know it has changed completely. Anticipatory grief can also entail relationship changes. So, for example, there can be a shift in dynamics in certain cases. Relationships can at times shift from a partnership to individuals feel like they need to either be the supporting individual or the individual that needs more support. An example of this is, for example, a parent is used to caring for their child. That relationship shifts as the child cares for the parent. Siblings are used to supporting each other, can shift to one sibling now depends on another sibling for care. A romantic partnership could shift into one partner is now supporting the other partner. And these shifts can happen both consciously and subconsciously. So sometimes it is evident the shifts that have happened, but sometimes these are small changes that kind of cumulatively come together over time. We can go to the next slide, please. Now we're going to talk a little bit about secondary loss. So what is secondary loss? These can be defined as losses that accompany the primary loss. So for example, finances. And these can start prior to a loved one's passing. So a really common example is finances. So for example, in a spouse relationship, both spouses work. However, now one spouse can no longer work due to medical changes, and now there's a loss, that secondary loss of two incomes. Another example is dreams for the future. So maybe there were plans for retirement, getting to travel together during those retirement years. Another example is for dreams for the future would be dreams and hopes for college for your child, and then your child has a diagnosis and all those dreams change and look different. Another example of secondary loss, we've talked a little bit about routine. So for example, in a lot of households, there are kind of either spoken or unspoken rules. For example, one person takes out the trash, the other person mows the lawn, the other person does the dishes. Well, if medical changes happen to someone and they can no longer, complete those tasks, the equilibrium of chores in the home change, and it can definitely shift the environment and put more tasks on one person. Another example is the secondary loss of a best friend. So, maybe the caregiver who is caring for their loved one, they used to be able to tell this person everything about how they're feeling. They felt like they could vent and just really let down around this person. Well, now they have lost that person that they feel comfortable confiding in. They don't want to burden their loved one who's going through multiple medical issues with their, everyday challenges or what they might consider to be trivial issues. So in other words, it no longer feels appropriate to vent to their loved one. And then another loss is sexual health. So this part of the relationship could have shifted or been removed due to medical complications, stress, a variety of reasons. And we can go to the next slide here. So what are some ways to cope with anticipatory grief and secondary loss? I think that or some ways to cope with this would include one, validation. So kind of validating what you and your loved one or the caregiver and the loved one are going through at this time. I know that the audience today is a combination of healthcare workers and caregivers and all types of participants, but I'm sure that there are a lot of healthcare workers in the audience today that are also caregivers. So I think it's really important to validate your emotions. So caregiving is one of the most rewarding and challenging jobs in the world. This is one of the only jobs that is truly 24/7, 7 days a week. Um, so, validation and sometimes, um, okay, I'm running a little bit low on time, so I'm gonna skip ahead a little bit. Support groups can be really helpful. Counseling support can be really helpful. I think for support groups, looking at your local agencies and seeing what support options are available can be incredibly helpful. Um, for counseling support, I know, for example, a lot of different oncology centers have counseling support for their caregivers. So checking into that resource. Um, and then self-care. I think that it can be really difficult at times to acknowledge that self-care is needed. And a lot of different local agencies will offer adult daycare support. Asking a trusted friend or family member to, just spend some time with your loved one while you're able to engage in a favorite art class, time at the gym, or, just being able to run some errands. I think that having that time for yourself is very important as a caregiver. And it's okay to utilize affirmations to address feelings of shame or guilt associated with caregiving or taking time for yourself during caregiving. So, for example, taking time for myself is giving me the strength to continue to support my loved one to the standards they deserve. And then we can go to the last slide here. There's actually two more slides. So just some final thoughts. The work you're doing is meaningful. It's okay to take time to rest. Grieving is a part of the caregiving journey. And you are not alone. There are people, resources, and organizations that are there to support you and your loved one during this time. And the next slide, please. Um, and then this is the QR code that you can scan for additional support services through OSU. And again, check with your local resources to see what is available. Thank you so much. I appreciate the opportunity to be able to present today, and I look forward to talking to you all later on.
Thank you, Alexandria. We really appreciate all that information and the work that you're doing at the James. Presenting next is Dr. Michael Hayes. Dr. Hayes is an associate professor of psychiatry and behavioral health and medicine at Penn State College of Medicine, as well as being a licensed psychologist specializing in cancer care. He serves as medical director of oncology care services, founding program director at the Kristen Olwine Milk Care Center, and psychosocial services coordinator for the Penn State Cancer Institute's Cancer Committee. He earned his doctorate from Marywood University, completed fellowship training at Johns Hopkins, and is a certified mindfulness-based stress reduction teacher through Brown University. Welcome, Dr. Hayes.
Good morning. Thank you for that kind introduction. And before I begin, let me just say how I'm both humbled and grateful to have a chance to be a part of today's forum. Every healthcare professional has had a similar experience. They enter an exam room with the patient in mind. Yet before the visit is over, they have also attended to the loved one who's quietly taking notes, the adult child who's coordinating appointments while balancing work and family responsibilities, or the partner who's wondering how to be both a caregiver and a spouse. While providers may have one patient on their schedule, they're almost never caring for just one person. That observation raises a question I've come to think about often. When we say we provide comprehensive cancer care, comprehensive for whom? For many years now, the field has embraced the concept of whole person care in oncology. We understand that caring for someone with cancer means attending not only to the disease, but also to the individual and their physical, their emotional, psychological, and spiritual well-being. Today, together, we are, a little nod to Penn State, we are being challenged to expand that definition. Cancer is never experienced by one person alone. The moment someone hears the words, "you have cancer," another journey begins as well. We heard today from Deborah, a spouse becomes a caregiver. An adult child becomes an advocate. A friend or family member steps into responsibilities they never anticipated. They accompany clinic visits, manage medications, monitor symptoms, and provide a steady presence that helps patients navigate uncertainty. As cancer care has become increasingly complex and increasingly home-based, the responsibilities of caregivers have grown too. Yet, despite the central role they play, caregivers have often remained the hidden partners in the broader healthcare landscape. When we truly believe in comprehensive cancer care, we have to ask ourselves again, comprehensive for whom? Next slide, please. At the Penn State Cancer Institute, the answer to that question is the Kristen Olwine Milky Care Center. The Care Center reflects a simple yet profound belief. Treating cancer well means caring for the whole person and recognizing that every person exists within a family, a partnership, and a community. As you see in this slide, these photos reflect, for caregivers, it is personal. One of the most meaningful expressions of that philosophy is our annual couples retreat for individuals living with advanced cancer and their partners. Next slide. Rather than describing it myself alone, I'd like to introduce you to some of the people who join me in speaking to its impact. So to describe this retreat, this experience, just in a word, it's magical. It's magical because here we provide a place and a space where people get to talk about what's real, what's true, what's most important, and often goes unsaid.
When I was given a stage 4 cancer diagnosis, I felt as if you're given an expiration date. This time here is important because it is restorative to your soul and it allows you to capture the value of whatever time you have and to kind of lose sight of putting an end date on yourself and just truly live.
I watch people come in with nerves and scared. And by the second day, they're holding each other's hands and they're supporting one another. So they go from the body language of fear to the body language of support.
Here they have that gift of
being supported in a safe way, and to let that out, put it in the light of day, and to realize there is hope.
It's a community. You immediately realize you are not alone.
I think this retreat helps realign the blessings that can occur out of something that is devastating.
Here at Penn State Health, we really focus on the entire patient experience, not just writing the chemotherapy orders and dealing with the side effects, really the entire person, the entire being.
We are so privileged and humbled that folks in the midst of facing advanced cancer invite us into such a private and deeply personal space.
We would not be going back with this new set of eyes, and we would have missed such an opportunity for really truly living our lives if we would not have come here. I mean, I wholeheartedly believe that.
Next slide, please. The couples retreat video captures something that statistics alone never can. It reminds us that healing is not always synonymous with curing. Sometimes healing is profound in strengthening relationships, reducing isolation, improving communication, and helping people experience that they are not alone. In this slide, that same commitment to caregiver-centered care is reflected in another initiative of which Penn State Health is proud to be a part of, our participation in the inaugural Insight training cohort. Insight stands for Increasing Caregiver Support Implementation through Training and Education, an NCI NIH-funded program being led by Dr. Allison Applebaum at Mount Sinai and Dr. Nicholas Odom at the University of Alabama at Birmingham. For us, Insight represents more than participation in an educational program. It reflects a commitment, one we hold deeply, to answering how caregiver support can become part of routine oncology care, not dependent on individual champions, but rather embedded in the way we educate our clinicians, design our care teams, and deliver care. How do we identify caregivers early? How do we understand their needs rather than assuming we know? How do we ensure they have the knowledge, confidence, and support they need throughout their cancer journey? Those are the questions that move us from good intentions to meaningful change. And they are the questions that bring us together today. As you listen to today's panel, I invite you to keep one question in mind. Who is the caregiver in the story you're hearing? Who is the caregiver in the story you're hearing? Are they visible? Like Deborah, are they supported? Is communication appropriate? Are they equipped for the responsibilities they're being asked to assume? Dr. Masnick pointed to this in her presentation. When comprehensive cancer care truly means caring for the whole person, it must also mean caring for the people who make that care possible. Our challenge and our privilege is to ensure that neither one walks the cancer journey alone. Thank you.
Thank you so much, Dr. Hayes. Our final presentation before our panel will be from one of our colleagues who I just think so much of, Dr. Nicole Stout. Dr. Stout is Senior Director of Survivorship and Wellness at the American Cancer Society and is an internationally recognized leader in cancer survivorship research and care delivery. With more than 25 years of experience, she has advanced survivorship guidelines and scientific consensus, published extensively, lectured worldwide, and serves as an adjunct research faculty at West Virginia University Cancer Institute. Welcome, Dr. Stout. It's great to see you, and I'll turn it over to you.
Thanks, Lindsay. What an amazing panel and really fantastic presentations that we have heard. I'm just thrilled to be invited to be with you all, but mostly I am beyond excited to see this focus and emphasis on the need for cancer caregiving. Many of the discussions that you've just heard illustrate so many different facets of the problem that we face in supporting caregivers. Really what it comes down to, we can be very well intentioned, we can have great ideas, but how do we execute on that? And that's really, I'm so glad that Dr. Hayes brought up the Insight program. The American Cancer Society is a supporting partner and a part of that work and that grant. And it really comes down to enabling healthcare systems to create the system of care that can help to support the caregiver. So I want to just share some thoughts and some insights. Haha, insight for the Insight program. I didn't do that on purpose, that just popped out. But how do we really take what you have learned and heard here today and move that into action? I like to think about what can I do Monday? What can I do to be Monday ready when I walk back into my clinic or my setting? Next slide, please. And I love this little cartoon. It's maybe bringing a little bit of levity, but I think it's very, very true. It is not just stress. It is not just busyness. It is not just overwhelm of doing a lot of things. All of those things happen for caregivers. But there is a real true manifestation of physiological change that also happens that can lead to tremendous burden of health, and that can translate into physical health problems that caregivers can experience. So it's important for us to think about the caregiver and the need for their meeting their needs and giving them support, not just because we need to alleviate their stress and burden, which is absolutely necessary and important, but the downstream weathering syndrome that they experience, the increase in stress, those things all can lead to physiological changes that manifest in poor health outcomes. So, if we really are about providing patient centered care, we have to think about the caregiver very tightly attached as that dyad to the patient and extend the tent so that we're really talking about patient and caregiver centered care, because the long-term health outcomes of both of those individuals in the dyad are really what matter. And bringing about this system of care is what we need to achieve. Next slide. So we've done some internal qualitative work here at the American Cancer Society to understand caregiver perspective, mostly around our ACS Cares. You may be familiar with our ACS Cares app. ACS Cares is an app that's free to download. I'm going to talk a little bit about it later when we go over resources. But it is a patient and caregiver facing app. And we've been building and working to build caregiver centric resources and a caregiver specific patient caregiver journey pathway. What we learned when we talked with caregivers were, not surprisingly, some of the things that you've already heard here. And you see the word cloud: overwhelmed, isolated, hopeless, fatigued, making a lot of decisions. So, although there is overwhelm, these individuals are very committed, of course, to helping their loved one or their family member. Next slide. What we've really been able to dive into is that there really are two major and different needs. Of course, the caregiver is there to support the patient in their journey and to bring about that support to help the patient manage appointments, get through the things that need to be done, drive them to appointments, help to support with meals, etc. They need information and they need resources to do those things. But the other aspect, and I think we've heard the data in this today and we've heard the perspective, is that we have to think of the caregiver as a unique entity. How do we identify their unique needs separate from the needs to support the patient? How do we give them license to say, I have problems, I have challenges, I need help too? Caregiving can be very lonely was one of the quotes from our participants. Recognizing that, asking the questions, bringing about the resources for those individuals uniquely, their unique needs need to be considered as well. So how do we think about that in an implementation and health systems approach? Next slide. I love this multi-level systems approach. I use this in a lot of my work. And it goes back to when we try to do things in healthcare settings, they're very complex settings, as you all know. There are things that have to happen at many different levels within the healthcare system. One person in a clinical setting who has a really good idea may be able to get something off of the ground. But unless we think about all of these different levels that influence what happens in that clinic, a team of champions, an educated workforce, infrastructure, workflows, IT systems that help to support caregiver assessment, caregiver resources and services specifically, we stand the risk of failing in implementing a strong caregiver program. So I think a lot about delivery system and intentional design. We have to go about creating caregiver specific programs using intentional design. And so, as I think through these different levels, from a very general perspective, I've given you some thoughts here about what are some of the strategies and what are some of the interventions that could be considered or done at each of these levels that can come together to help a successful creation and implementation of a caregiver program. So, thinking about your clinical professionals, your workforce, how do we educate them? What do we rely on as far as knowledge and skills and training to build their knowledge and awareness of the caregiver as a unique entity and the caregiver resources? At the clinic level, how do we enable our clinic workflows, shift staff tasks, shift our resources so that we're screening and documenting appropriately when we identify caregiver needs? Our health system survey recently identified that very few out of 110 survey respondents that we received, specifically looking at CAR-T therapy programs, we asked about caregiver documentation. 99% of those health systems documented caregiver awareness, caregiver needs in the patient's medical record. So that's lost. That's lost in translation and it's lost to the rest of the medical team. So, really thinking about how we disrupt our clinic workflows to focus on collecting that data, measuring our interventions, and improving health outcomes. And that becomes a health system level trigger that helps us when we can collect that data, when we can show that our interventions help to support the caregiver and contribute to better long-term outcomes. That helps us identify and bring on board more administrative champions. It helps us build our network. It helps us to create that ecosystem within the healthcare system. I always say very little. We always start in the healthcare clinic and say, oh, we want to implement this new thing or this new program or this new screening tool. But the reality is, where I have to start with that is not just bringing that thing into the clinic. I have to start with getting administrative buy-in. I have to start with getting a team of champions. I probably have to start with some policy changes. So thinking about that intentional system design. Next slide. Now, we do have some resources to give us guidance around caregiver-centered competency domains. This is focused on the healthcare professional. So how do we create education? We have competencies that can help us educate our workforce. How do we train our staff around the appropriate tools for screening? Navigation strategies and creating those systems of care, the screening tool implementation in the clinic. How do we communicate to caregivers? Recognizing the role and then really fostering resilience among the caregiver, but also alongside that dyad of the caregiver patient relationship. So there are competencies that we have used to drive education and training for the health professional workforce. Next slide. What I think about a lot and what I do a lot in my work is implementation. And really, what it comes down to, if we think about implementation to a clinical workflow, you can distill it down and ask the simple question, Who does what, when, and how. And if you work through that framework, as you see here, if we're talking about screening, how do we implement a caregiver needs assessment or a screening tool? How do we conduct interval screening? How do we create a navigation program or a navigation pathway? How do we connect caregivers to the appropriate resources? What it comes down to is who does what in your clinic, when, and how. And across each of these characteristics or these factors, if you will, the answer is there could be many different answers. So, who could conduct a screening or who needs to be part of the clinical workflow screening? It could start at your front desk. It could even start before that. I'll tell you how many of you are getting, oh boy, I know we all are. How many of you get the text messages and the emails? Prepare for your upcoming visit. Fill out this questionnaire for your upcoming visit. What a great opportunity for us to engage a patient and caregiver, ask them screening questions, identify then who is going to be the champion to use that information and connect them to document that information and then connect them to the resources. So working through this matrix and thinking about this will look different in every clinic, in every setting. So there's no right answer, but it just really helps you to frame your thinking around how do we get this into our clinic workflow. Next slide. So I love this framing also. Each encounter is an opportunity. Ideally, we'd like to screen and assess unmet social needs and unmet needs in the caregivers from the time we see them in the healthcare system, from the point of diagnosis. We'd like to repeat that at 1 month, at 3 months, at 6 months as the patient moves through treatment. But really, any encounter is an opportunity. Educating, screening, thinking about a formal approach to screening, moving those screening findings towards evidence-based interventions, and really then following up to close the loop. Consistency in staffing really matters. You heard that. A social worker walked in the room that we had never seen before. I feel like that's a failure of our system. That's a failure of our system to provide consistent caregiver and patient-centered care. Next slide. The other piece of this that becomes critical is community engagement. Really recognizing where your community resources lie, how you connect individual caregivers based on their needs to the appropriate community resources. A multitude of engagement strategies that exist, working with your community partners to help to develop that resource guide, building partnerships so that there's an increase in awareness of caregiver needs in the community and with community resources. Next slide. So when we think about community engagement and strategies, thinking about what exactly are the needs that we are addressing. Caregiver needs, as we said, span the support for themselves. So how do we find those resources and tools? And then also being able to give them the tools that they need to support their loved ones. And then thinking about how we leverage community-based resources to meet those needs. Something as simple as grocery delivery, lawn care, supporting activities like that, bringing those support factors into the home to help ease the burden of the patient and the caregiver. Next slide. I'm also appreciative that earlier on we heard some discussion about the cancer caregiving in the USA. That was the 2016 report from the National Alliance for Caregiving. I do want to share with you that the American Cancer Society is a part of NAC's Cancer Caregiving Collaborative. And the focus here are core priorities, as you see, healthcare integration and financial support. So we're really looking at how do we create processes? How do we help to facilitate the implementation of these resources, of these systems into cancer care delivery? So healthcare integration and implementation is all part of it. Next slide. And there are a number of resources here that can help to support you in that realm, developing a program. Identifying resources around financial toxicity, understanding implementation trends in caregiving. So, a number of resources to help you fit this all into how do we do this in our clinic workflow. Next slide. I want to share with you, we are undertaking this year many different actions within the American Cancer Society to improve caregiving in the cancer clinic. This is a healthcare workforce facing Echo series that will be starting in October. You can see the session dates and you can see the times. Everything is here, and you can even register already. We have not even started to promote this. The Echo registration just went live yesterday. But we will be beginning in August. The target audience here are healthcare professionals, but this is an open echo. Anyone can attend. What we want to do is give you the tools and resources to start thinking about how to implement caregiving processes within your clinics. Next slide. And I'll leave you with one thought. And this really came to me after hearing the discussion this morning and hearing Deborah's story. Deborah, when you told your story, it was an incredible and moving and sad story. But the thing that got me the most was when you came on at the end and you apologized for not wanting to sound like you were criticizing your healthcare team. That's a problem. That's a problem that we in healthcare need to remedy. A patient and a caregiver should never feel like voicing their concerns, voicing their opinions are a criticism or should be taken as a criticism. We should empower our patients and caregivers to share that feedback. It's only then that we can step back and learn and reflect on how we do it better. So, Deborah and others, please keep bringing the feedback, keep bringing the dissent, keep bringing the challenges forward that you have faced. Without the guilt, I hope we can create an environment of a safe space for people to bring those comments forward and take those with the intent that they were delivered. How do we make this better? We listen and we learn. Thank you.
Thank you, Dr. Stout. Just always one of my favorites to hear from. We've heard several perspectives today on the importance of caregiver support during cancer care. Now we'd like to bring all of our presenters together to discuss where these ideas align, where they differ, and what's next. Here to moderate our panel discussion is Jill Settlemeyer. Jill has been the executive director at Cancer Family Care in Cincinnati since 2013. She made a career change from education to nonprofit management after her son was diagnosed with cancer in 1998 at the age of 13 months. What started as an American Cancer Society Relay for Life volunteer role turned into several roles as an ACS staff member, including positions as executive director, regional vice president, and senior vice president with the then Ohio division. Welcome, Jill, and our panelists.
Hi, everyone. I'm going to start out just by thanking all of our panelists for those great presentations on caregiving. Lindsay mentioned my son was diagnosed in 1998. And when I think about how far we've come with addressing what the caregiver needs, I'm very encouraged and very hopeful for what's to come. We've had some great questions, and so I'm gonna jump right in and start with one, and I'm gonna address this one kind of to everybody. But how can health systems better identify caregiver needs kind of early on in the cancer journey with families?
Well, I can jump in and start here. I think it came out in a couple of the presentations that there there has to be a systematic way to do this at the entry point into the healthcare system, but then throughout the trajectory. Because health caregiver needs change over time. And so it can't be one and done. It has to be at various checkpoints. So if it can be systematized into the workflow, that that is probably the best way to get it done, in a systematic way. However, though, I think, Nicole and Michael and Alexandria also brought out that there has to be an individual commitment to recognizing the caregiver in the room and taking that minute to ask how things are going, how are you doing, ask about them and their story of caregiving. It doesn't take a lot of time, but that is another way to continually try to assess their needs.
If I may, I'd like to thank Susan for that response and add, fundamentally, I believe it's paramount that this becomes standard of care. It's simply what we do for everyone across the board. And when it is standard of care, then systematically we're assessing, doing that longitudinally, and we see the caregiver right alongside the one they're caring for as our focus.
I could not agree with those statements anymore. But I will also add the process is important. The discussion with the patient and the caregiver together is important, but the caregiver separately also matters. The other thing that I would suggest we have to systematizing, absolutely, I agree with that. I think we have to recognize also that there are unique tools that help us to do health related social needs assessments. And there are unique tools that we can use to assess caregiver burden. That doesn't mean assessing your caregivers using the distress thermometer. And unfortunately, that's what we see a lot of. We see the same tools and the same questions that are asked of the patient being asked of the caregiver. Those insights may be helpful, but we also then have to realize taking that away, finding and connecting to the resources are different to support the patient grieving and to support the caregiver grieving, are different to support the patient medical needs and the caregiver health related needs. So, really thinking about those as not just we're in the room with patient and caregiver, hey, how's it going financially? How's work? Because the answers from each of those individuals will probably be different and probably be nuanced and will require us to take a nuanced approach to managing.
It's great.
I just think if we are assessing caregiver distress, which I do think is important, that's just the tip of the iceberg. And I agree, Nicole, we need to take time to talk to caregivers away from the patient because they are often hesitant to discuss their true concerns. And you know, caregiver distress, then the clinician needs to start to dig a little bit deeper about what is the source of the distress. Is it about doing this new procedure? Is it about managing work? Is it about managing family? So that it's just an initial screen, but it shouldn't be seen as just a number and a cut point for the next step. Further discussion is needed. I agree.
I think something that is also very important is assessing specifically for um, past mental health diagnoses. I think that's also very important when considering screenings and asking the right questions. Because I think that because caregiving is such an emotionally, physically, spiritually at times, financially taxing role, that any predisposition to mental health in the past, I think that's a very important factor to consider to ensure that caregivers are being supported at the level of care that is needed.
Those are really, really great responses. And kind of as a follow up to that, thinking about just the distress screening for a caregiver, what happens next? What's the next step in that? And one of the panelists mentioned medical documentation in the patient's chart. What about the caregiver? If it's the caregiver that's having the concern, is there any good examples out there of how that is then being communicated to maybe the caregiver's, primary physician or family physician? Is there any kind of crossover being done there? Any good examples out there?
Well, I can just from my experience with my research study, there were many situations where we were very concerned about the caregiver participating in the study. And we had to follow our protocols through the IRB. But one thing we did is we encouraged the caregiver to contact their primary doctor if it was a health concern. But what we also did is we let the healthcare team caring for the patient know of the caregiver's distress or the caregiver's concerns. So then the clinical team could meet with the caregiver and help them and get them referred to the appropriate resources. But we don't have in the clinical situation, we don't have the caregiver's medical record or things like that.
Yeah, there's really a lot to think about there from the health system's perspective and a medical legal perspective that I think is we may be well intentioned in saying the caregiver needs to have an electronic health record also as a caregiver, or we need to be able to access their record. But we really need to think again intentionally about how we would design that. We did have some of our health system survey respondents to sites that actually said they have set up dedicated caregiver charts within the electronic health record, which is interesting because EHRs are structured not to collect data so much as they are structured for billing and coding purposes. And so if we're not documenting to bill a caregiver, I think a lot of systems would not recognize the benefit in creating an electronic health record. So I do recognize a lot of the documentation goes into the patient chart, which I think is an okay process if we have someone with a dedicated role that's attached to following up with the caregiver and the patient, whether that's a navigator, whether it's a specialty care nurse, a social worker, however that's constructed in your system. But paying attention to those unique, documented, and identified findings about caregivers' unique distress and burden. I think it's a challenge in today's world of electronic health records. It sounds easy, but it's quite difficult to do.
So, kind of next question I have that's come from the audience is, and I think about my own situation when my son was 13 months, and I should actually say he's now almost 29 and healthy and happy and no residual effects and all of that. So nobody's wondering. He's good. But even thinking through, caregiving with him, as a 13-month-old, he was diagnosed and a central line was placed. And we were in the hospital for 8 days, and then they sent us home with a central line and central line care, and so not only are we dealing with all of that, we're dealing with the emotional stuff and now the physical stuff. So how can cancer programs better train the caregiver on the medical things that need to be done for the patient? Thoughts on that? Susan, I know you have some experience with that as in nursing care.
Yes, and if they're in an inpatient setting, or many of the procedures now are done in an outpatient setting and at very odd times during the day, and they're often sent home without very much training in how to handle tubes and devices. So again, the clinician, the nurse often needs to take time as they're training the patient, if it's an adult, as well as the family caregiver in the steps of the type of technical skill that they need to do. They use the teach back method, which is slightly different from simulation, but they would use the teach back method to make sure once they show the caregiver the skills, that the caregiver skills then demonstrate back and ask questions. And they need to do this more than once. It has to be done repeatedly. There needs to be print material that is appropriate in terms of health literacy with diagrams on how to do it, perhaps online resources for technical skills, and a phone number to call when they're at home and a issue is happening and what they've learned they're not picking up. Also, visiting nurses are helpful as well, of course.
Yeah. And again, I think about how far we've come with that. I mean, I think about it now, and I think, I could watch 20 different YouTube videos on central line care that we didn't have before. So I think making sure that caregivers are aware of some of the resources that are out there, I think is a big piece of caregiving. Any thoughts on that, on how you get that message to the caregivers? And Alexandria, I'm assuming you're seeing a lot of caregivers in practice there at the James. So how do you get those resources not just to the patient but to the caregivers?
Yeah, so part of our screening process is we reach out to the patient and we just let them know about the caregiving resources that are available during our initial phone screening. I think it would be incredible to have a process where we're able to screen the caregivers as well in the future. That I think that would really help, because I think that, asking the patients and talking with the patients, sometimes the caregiver's present for the phone calls, sometimes they're not. And so I think just making sure to fill in those gaps would be helpful, but we do the best that we can to share consistently with the patients. These are the caregiver resources that we have available. And I think that, so basically, if they're interested, they can call into, they can call a specific number and say, "Hi, I'm, the caregiver of this patient. Can I please get set up for caregiver counseling?" And we have really, what's the word? We really make sure that their privacy is protected. We have, for example, if I were to meet with a patient, we would have another counselor meet with the caregiver. So that ensures privacy. I think another point I wanted to make on that note is that patients can ask for their notes to be blocked from MyChart in our system. So they're able to say, "Hey, I'm not comfortable with this note being in MyChart. Can you please block it?" And we can flag that chart for please block psychosocial notes. I think that is one thing that can be challenging, is sometimes being in a shared chart. However, if they're really worried about it and not comfortable with it, we also have outside resources. Like, for example, there's an amazing resource I meant to mention during my presentation, but psychologytoday.com. If you use that website, you can type in different filters. So for example, caregiving, cancer, and you can put in the zip code of where you live, and if you would like telehealth or in person, and your insurance, and a list of available providers in your area and network will pop up. So I think that is an amazing resource. And so we try to make sure that that service is shared and talked about consistently. And if a caregiver is present during appointments, talking about those resources. And I think just collaborating as well with their providers and just making sure that kind of all boxes are being covered and that individuals know about it, and also mailing those resources to individuals who maybe their internet's finicky, if they live in a rural population, or just making sure that we really have that information accessible in a variety of ways.
Great points. So just in thinking through, some of the things that I know, that I experienced, and that some of the folks that we work with here at Cancer Family Care, we know that there are sometimes, let's just be real about it, disagreements between what a caregiver kind of sees a patient needs as opposed to what the physician or the medical team needs. Any thoughts on the best approach to kind of help repair some of that trust that can occur?
I think advocating for individuals, I think just just encouraging patients and caregivers that they always have a choice. So it is, I mean, this is, as Dr. Hayes mentioned during his presentation, it's personal. And sometimes emotions can go from 0 to 100 in a span of a couple minutes in an appointment. So I think one thing to keep in mind is, deep breathing always helps with slowing down the central nervous system. And just reminding, patients and caregivers that they do have options. There are second opinion clinics, there are third opinion clinics. And always wait 24 to 48 hours to process the information, because I think any initial information, sometimes it can feel very, surprising, and it can catch individuals off guard. And it is personal. The information that the medical providers are giving to patients and caregivers could change their entire lives, the next 6 months, the next 10 years of their life. And so just encouraging patients and caregivers that it's okay to take time to think about things. You don't have to say yes or no right away. You can give things time. There are so many amazing providers out there. There are so many amazing health systems, and just advocate and encourage patients that they do have a choice. I think that sometimes it can feel very overwhelming to feel like there's one option, one choice, because that couldn't be farther from the truth.
And I'll just add a point on that there was something that happened with my son's care, and I recall a nurse saying to me, "I'm really sorry that this happened," and that is something that 28 years later I remember, and I will never forget that someone from the medical community said, "I'm really sorry this happened." Not I'm sorry we made a mistake, not I'm sorry this, but I'm really sorry this happened. And that went a long way for trust. So I think from the provider perspective, making sure that, that you are communicating that with the caregivers if it is something that happens. And so it's not just always to be put on the patient and the caregiver, but then also back at that. So just from that personal standpoint,
Yeah.
kind of owning that.
Yeah.
And Dr. Hayes, I'm going to address a question to you that has come up. Caregivers are often given, we get really clear guidance on monitoring and reporting physical symptoms, a fever or a rash or something. But any thoughts on providing some guidance to caregivers on how to identify changes in mental health with the patient? Because oftentimes the patient doesn't say, "Oh, hey, I'm suffering, I'm sad, I'm mad, I'm angry," but it's being taken. The caregivers are the ones that are realizing that. So, any thoughts on how to help a caregiver kind of recognize differences in their loved one?
It's an excellent question, Jill. Before I respond, I'd like to just add a comment to what was said just before. I think it's important that we always remember who we work for, who we serve. And with that, how important it is for us collectively in the healthcare arena to have that servant mentality. And I think that can go a long ways in establishing respect and trust. Let me understand where you're coming from. Let me make sure I understand if there is a question, what's underneath that for the individual. When I meet with people, the very first appointment I meet with people, I say to them, I'm always reminded that I came to work today to work for you, to serve you. And it can, I think, really help shift the landscape, and that we're partners here, right?
Yeah. Beautiful.
In terms of the mental health piece, you mentioned being the mother of a young child who's now 29. Wow, congratulations. I don't know that there's any special training that's needed. I think that often those closest to us read us like a book. And the patient may not be disclosing their emotional or mental health challenge or concern to members of the care team. Um, but more often than not, those loved ones, they see it, they read it. It's often unspoken. You just know. In the land of mindfulness, we talk about those emotion mind, the gut feeling. And there have been occasions where my wife has said to me something about our sons, and I'll say to her, "How do you know that?" And she'll say, "I just know." And I'm like, "No, how do you know that?" Maybe it's a guy thing. In dollars to donuts, she's always spot on. So in this way, I think it's important that we invite opportunities for those conversations to occur. You know, is there anything that you're noticing that gives you pause? And we don't necessarily need to frame it as mental health or as pathology. You know, we pathologize so many things in our society today, but really just to open up that space and fundamentally know that healthcare is delivered in the fabric of relationship. And as we establish that this relationship you have with your loved one and what you know and understand about them, it's valuable data. It's every bit as valuable as the blood work and the imaging and pathology reports. Um,
Michael, that was so beautifully said. I wish you're the kind of that's the kind of mentality and you're the kind of person I'd love to I like to say I'd like to bottle you up and just be able to spray you all around because we really need that thought, that deep sense that you're conveying in how you operate. We really need that to become part of the fabric of how we deliver cancer care and caregiver care. I've heard a few things just in these last few comments that I'd like to just draw upon. Number one, Alexandria, I love how you said emotions can go from 0 to 100 in minutes. I would say a flash, a blink of an eye, seconds even. And I think sometimes that communication breakdown comes because we haven't done the hard work that you've talked about, Michael, which is developing the relationship, getting the trust built. When it's a one-off comment from someone that the caregiver has never met before, that can ignite those feelings. But when we've had ongoing, repeated conversations. Sometimes we may feel, we as providers, I feel all the time, sometimes I say the same things and repeat them again and again. But a lot of that's because there are times when patients and caregivers are prepared to hear that, and there are times that they are not. I call it repetition saturation because the more that we can engage repeatedly, in the conversations, the more it helps them become open, the more it helps them process. They may need to hear things several times. And unfortunately, our caregiver support systems are rarely set up that way to provide that consistent individual with whom they can build trust. That process whereby we repeatedly engage with the caregiver and the patient, this interval, because that caregiver and patient on day one are very different in on day 30 and in 3 months and in a year. So those interval check-ins and recollecting where they came from, who the problems they've had, telling that story that you understand and that you are there for them, they will believe in that when you really do walk alongside them through the trajectory of care. But if it's sort of a flash in the pan, I've had patients say, boy, that social worker came in the beginning and that was 6 months ago and we've never seen them since. They gave us all these brochures. They were really great. They told us there were all these resources and we've never seen them since. And then you talk to the social worker and they say, well, the patient caregiver never asked. We cannot wait for caregivers and patients to ask us for things because chances are they won't. They're afraid to say, my pain's getting worse, his pain's getting worse. They're afraid to say, financially, we're really having a tough time. They're embarrassed to share those things. And so we can't wait for them to tell us. We need to be positioning the questions and the resources prospectively. The more that we do that and come alongside, the greater trust we build, but also the more robust pipeline we build for those things to come to bear. And it's not, oh, there was a social worker 6 months ago, and the social worker says, no one ever, they never asked for these things. We patients don't know what to ask for, caregivers don't know what to ask for. And even if they do, they may be hesitant. So, us introducing repeatedly over time, I think helps to smooth that pathway so that feelings tend to be less escalating quickly, tend to be less abrupt, and there tends to be less tension, but it also tends to be a more supportive approach.
Nicole,
And
oh, sorry, excuse me. I just want to say
no, go ahead.
I agree. And, we need to empower family caregivers to raise these concerns with the caregiver in front of them. Because often it's not a consistent caregiver, as you know, in these big systems. And so a change in how they're, how it's going at home or the emotional or mental status of the patient, that all needs to be brought forward because it may be related to something, more serious in terms of the medications and things like that. So we do need to empower them. The other point I want to bring up is that patients with cancer and their caregivers are interfacing with numerous departments in a big medical center. Routinely, walking into the emergency room, the lab, other departments. So there really is a need for handoffs in between therapies, but also, we need to instill throughout a system a culture of patient and family-centered care and respect for the individual and the respect for the family caregiver. It really needs to be a top-down approach as well from the clinical team.
And I think too, I want to just bring up a point of when working with patients and caregivers in the clinical sense, something that is very common is that the patients and caregivers will oftentimes second guess their like that they need to be there. I noticed that a lot that they will second guess of, well, I don't know if I really need this, but I'm here and should I come back? And so I think that it's really important for the provider to encourage the consistency and encourage if yes, you are going through a lot and just that validation that I discussed in my presentation. I think that's really important because I see it almost in every patient and every caregiver. They start to question, do I really need counseling support? I feel like I'm doing okay. And so they look to the provider to encourage, yes, you should be here. Yes, this is great that you're here to take this time for yourself. And I just always like to encourage patients and caregivers, if anything, this is an hour you're setting aside in your, hectic and busy life to really do a check-in of how you're doing and to talk. And it's okay to talk about different things. And I think that, grief and gratitude can exist simultaneously. And people like caregivers and families may feel like they're at the best place in the world for their care, but it's okay to vent a little bit. It's okay. It doesn't mean that you're not grateful and you're not, experiencing so much gratitude. It's okay to just talk about some of the challenges because it's not in black and white situation. It's gray. It's not all or nothing. Everything is an amazing or everything's awful. A lot of times it's, well, this was amazing but this was challenging, and the communication was amazing here but maybe I wish it would have been a little bit better here. And so I think just encouraging that is okay and that's normal, and just to be a listening ear and can encourage that follow up, I think is huge for patients and caregivers.
Susan, there's another point that you made that I don't think we've really touched upon deeply here that is critical, and that is a caregiver isn't always a spouse. It may be,
Yeah.
but it may not be. It may be a neighbor. It may be,
Mhm.
a church a friend. It may be a daughter or a mother, as you've said,
Mhm.
Jill. So really recognizing, and it may change, right? There's a different caregiver along for the ride. And this is all the more reason why consistency with provider, consistency with documentation, consistency in understanding that individual in front of you is so important. I've been a caregiver for my dad. I used to be the heavy that would come into the healthcare system and lay down the law when there were problems to help to fix them. And that was kind of the role that I took on in our family dynamics, being the caregiver. My sister was the nurse. She handled the medical stuff, and those questions. So, recognizing that different family members and friends might play different roles and really understanding those dynamics, and how that can influence the patient experience, but also how we need to interact with the patient and caregiver.
Mhm.
A question that was asked of the audience is kind of been thinking through the caregiver and patient relationships. Whether it is a spouse or a neighbor or whatever. When the caregiver is saying, "This is what I'm feeling," or "This is what I'm going through," or "This is we're having financial issues," but don't tell the patient. Any thoughts on kind of working through that piece? Because we've all nodded our heads, we've all seen that, and how you're working through that with patients and caregivers.
I'll take a stab at that. It is common. And one of the things for me that's really central there is the importance of respecting boundaries. At the same time, working to encourage that individual to find a way to be able to communicate what they're saying to me to their loved one. How can I support you in finding a way to be able to say whatever it is that's being addressed to me? And I often underscore that fundamentally, whatever is going unspoken is often the most challenging thing. And we need to find ways to crack eggs, and to do that respectfully, safely, and in a way that's constructive for both.
This was really a great panel. Thank you so much for all of the insight that you've given. I'm just going to encourage one final thought from a caregiver who has now in the caregiver space, professionally now, but looking at you all as caregivers yourself and making sure that kind of the strategies and the things that that we're encouraging patients and caregivers of those patients to do, that you're doing for yourself as well. I think that's really important because as so many of us have worked in cancer, but also taking care of someone with cancer, and sometimes at the same time, don't forget about yourself as a caregiver. So that's my final thought as I kind of hand it back over. And thank you all for those thoughts.
Thank you so much, Jill. I think that was the perfect way to end. We really appreciate all of the time and insight. It's been invaluable. I'd now like to welcome back Nicole Stout to share a few ACS resources with us.
Thank you. One of the things I love to say is if it's free, it's for me. And the nice thing about the resources that we've developed is that they are all free, available for you to download. You can print them out, you can share them, you can keep them for yourself, you can post them on social media, you can share them with your teams. So we have developed and are continuing to develop a robust resource library in the caregiver space. So we have resources that are focused on helping caregivers, but we also have resources that are focused on healthcare professionals who are interested in doing more in this space, understanding how to do better screening, documentation, many of the things that we've talked about. Yeah, go ahead to that first slide. Thanks. This is our caregiver support resource. It is one of our most highly downloaded resources at the American Cancer Society website. It is a fantastic resource guide for caregivers to use that we can give to caregivers. So this is for the caregiver themselves. It talks about some of the very nuanced things that we've discussed today. Yes, managing medical issues. Yes, managing appointments and billing and insurance issues. But it also keys in on some of the more unique needs, like how to seek help in managing some of the challenges that are unique to the caregiver. It also talks about self-care strategies and techniques to find and help to identify respite support, as well as the emotional and the physical impact on the caregiver. So this is a tremendous resource for you. I've put the QR code in here, or you can always Google it or look on cancer.org. Next slide. One of the things that I'm really proud of, and this has helped to form the basis of the work that we are helping to support with the Insight program. We worked with a group of subject matter experts about 2 years ago to create a toolkit for cancer centers and cancer care staff to help them develop caregiver clinical services. Again, this is a free resource for you to use. If you're walking away from this today and saying, let's get started, this is where you want to go. You want to download this resource. Go ahead and take to the next slide. Because this resource outlines for you across multiple chapters the ways that you can begin to move towards creating and implementing a caregiver clinic or a caregiver specific service line in your hospital. Now, you can choose, that can be done caregiver clinic light, or it could be caregiver clinic service line. We're going all in with dedicated staff and an electronic health record and marketing tools and evaluation metrics. Or we just want to set up a process whereby we start to do a better job identifying and screening and working with our caregivers. This toolkit is a great resource for you to take a look at, think about what resources you have in place and how you can begin to leverage those resources in a better, more streamlined way to begin to manage caregiver complex needs in a better way. So this is really the foundation for what we have seen Dr. Applebaum and Dr. Odom then develop into the Beautiful Insight program. Go ahead to the next slide. I talked earlier about ACS Cares. This is Community Access to Resource Education and Support. ACS Cares is an app. It is free to download. And when you log into the app and create an account, the very first thing it asks you, are you a patient or are you a caregiver? And we have gone through great lengths to create specific algorithms on the back end of this app that are unique to the caregiver. So when the caregiver says, yes, I am a caregiver, and the next thing it does is it takes them to a screening tool that is a unique caregiver burden screening tool. And the caregiver can also ask questions about their patient's needs or their loved one's needs. It can ask questions about filling and meeting their own needs. But on the back end, what we do is we drive two different pathways, one that is more patient facing and one that is more caregiver facing. This has been developed with support from some of our amazing partners that we work collaboratively with through the National Alliance for Caregiving, Cancer Care, Caregiving Collaborative. It's a lot of C's. But ACS Cares is a free resource. We have just launched this spring the patient journey perspective. So instead of just coming into an app and saying, I need information about fatigue or I need information about financial resources, it takes you through a care continuum perspective. Where are you in the trajectory of care? Where is your loved one in the trajectory of care? And when you click on that, it will portray for you some of the things that you might be experiencing. So as I said before, we can't wait for the caregiver to ask. We can't wait for the patient to ask. So what we've tried to do in operationalizing the new CARES patient journey is to pose the issues to them and say, you might be dealing with some of these things. And if you are, this is where you can find help. Next slide. We have also doubled down on our support in complex caregiving, specifically with our partnership with Kite Pharmaceuticals around CAR T, chimeric antigen receptor T cell therapy. This is a highly intensive cellular therapy that requires a caregiver be present with the patient for 24 hours a day, 7 days a week, for between 2 and 4 weeks in order for them to even be medically qualified to receive the therapy. So it's a complex transplant cellular therapy. And we have been diving deep in creating specific resources in the CAR T cellular space, understanding CAR T cell therapy and its side effects, managing those side effects, but really diving into resources for the caregiver that is supporting 24/7 supporting these individuals. Next slide. So hopefully those give you some insight to the caregiver resources. I also shared the ECHO program with you earlier. Please join us. It is free. I forgot to say there will be continuing education units. We're in process of applying for those for nursing, for physicians, and hopefully for social work. So stay tuned. We will launch that ECHO program. It is free. It is open to anyone. You can attend all 6 sessions. You can attend one. So take a look at that schedule and outline, and we hope to see you and join the ECHO program. It's a great interactive way to learn a little bit, share a little bit, and learn from the community. So thank you for the opportunity to be here.
Thank you, Dr. Stout. We are very pleased to announce our upcoming forum sessions. In September, we will focus on tobacco cessation, and in November, mental health and cancer care. We hope that you will join us for each of these. We are also pleased to share that this program and all previous programs in the series will be available on YouTube. CMEs are only available for the live event, but please share what you have heard here today with your colleagues, or you can also check out some of the sessions that you may have missed. The CME certificate will be sent out in 2 weeks. It'll be a follow-up after you complete the post-event survey. The survey will pop up at the close of today's session, and you will also receive a post-event email with the recording of the session and the survey link in case you missed it this morning. If you do not receive the email tomorrow, please check your spam or other folders. Thank you again for joining us today and for your commitment to fight for a world without cancer. Have a great day.